here with you guys. All right, well, thanks everyone for spending your afternoon here at this session. This is a joint session of both the neurological emergencies and EMS interest groups, so we appreciate their support in this submission. My name's Chris Richards. I'm an EM and EMS physician at University of Cincinnati, but I also do a lot of acute stroke. I actually co-direct our stroke team and take stroke call primarily as well. So my world kind of interacts in the world of pre-hospital stroke, so I'll at least find this interesting. I hope you guys do too. We have a great panel. I'll have them introduce when they come up, but I do want to lay the land just a little bit before we get started. And that is first to say that stroke treatment is time dependent. Even for, since 2015 when we had endovascular studies, even well within guideline recommended treatment for endovascular, time still does matter. And so to basically deliver that efficient care, the concept of the stroke chain of survival has been developed with multiple steps. And usually when I frame this for my paramedic colleagues, I kind of say the chain is only as strong as its weakest link. And so every part of this chain of survival truly is important, but there's so many pieces, there's so much that goes into this that every part along the way here is important. Now, I sometimes bucket this also into half of this really being in the pre-hospital space, and that's what we're going to talk about today. A lot has been talked about in the emergency department. But it is true that when our paramedic colleagues and EMTs pick up stroke, these patients do a ton better. A lot of good things happen. So this is out of the Greater Cincinnati, Northern Kentucky stroke study, all strokes in that tri-state area. And if medics pick up a stroke, 2.5 times greater odds of receiving thrombolysis, and they receive thrombolysis about a half hour sooner. So when we are in EMS and we think about what is our overall mission, right care, right time, right place. And so thinking about matching type of stroke center to the presenting chief complaint, these sort of concepts have led into AHA recommendations like this, where it says, if you have a patient that you think is having a large vessel occlusion stroke or a hemorrhagic stroke, maybe they should go to a thrombectomy-capable stroke center or a comprehensive stroke center. And these recommendations have been modified for the setting of the EMS agencies, but ultimately have been adapted into EMS protocols like ours here in Southwest Ohio that say, hey, if you have a severe stroke, go to a stroke center that can manage that. Now, ultimately, these are just screens. They're not perfect. And so ultimately, if you don't have a perfect diagnostic instrument, there's going to be over and under triage, which our panelists will talk about in terms of that effect, very specifically on the patients in the pre-hospital setting, but then also these effects in the emergency department. So Dr. Cooley is going to talk a little bit about just what these scales are, but also importantly, how these have been adapted into an EMS system. Dr. Mamer and Dr. Panagos will talk about the implications for the patient in the pre-hospital setting. Dr. Netwinch and Dr. Sosner are going to talk about what that really means for the hospital and the emergency department. And then we had initial panelist, Dr. Ganti, who had to be called back on a red eye last night, so I'll talk a little bit about future innovations at the end. But really, we want to hear from you all and our panelists what your thoughts are on the topic. So, Dr. Cooley, let me have you come up, and we'll start with you.
Do this and get you started. Thank you very much. Okay. So I'm Craig Cooley. I am our department's EMS division chief and fellowship program director, as well as one of the deputy medical directors for San Antonio Fire. I don't have any disclosures, but I do want to acknowledge actually two people, Dr. Miramontes, who's our medical director for San Antonio Fire, and then Dr. Birnbaum, who is our endovascular neurologist who runs our LVO program. They were really the champions of this program for our system and everything, and they also let me borrow some of their slides. So we're going to go back a little bit further, though, in how we got to where we are, talking about the collaboration and with EMS. So this kind of started probably 2016 or so when the hospital said, hey, we're trying to get those door-to-needle times. Can EMS maybe draw our labs in the field so that'll speed things up? Anybody who's ever worked in an EMS system that's done this knows that's a terrible idea, and we politely said no, but let's see what we can do. So San Antonio is pretty unique. We actually have seasoned, multi-year experienced clinical paramedics in our dispatch, which means we get to do a lot of of really cool stuff and for another talk. But it also means we don't really do the dispatch cards and the scripted language like you see in a lot of dispatch centers. So we said, you know what we do is great in a lot of ways, but we need to get back to the basics and really focus on these, ask these questions and figure out, hey, is this really a stroke or not? And if it is, then they send a dispatch message to the computer as well as over the radio. It says, hey, drive safe, drive fast, but let's get there and start moving to get the patient off scene because we think this is a real stroke. So when the engine crew gets on scene, which is usually made up of 4 personnel, we do have medics now. Back then, we had a combination of EMTs and medics, so it varies a little bit. But they're going to do the basic stuff, and they're going to really focus on when were we normal last, so we can kind of figure that out, and then start moving the patient kind of, how are we going to get them out of the bedroom, how are we going to get them down the stairs. So when the medic unit shows up, 3, 4, 5 minutes later, their first thing is to bring the stretcher to the door, which would seem obvious, but we only have about a 40 to 45% transport rate in our system, so they often don't take the stretcher in. So knowing, hey, this patient's likely heading to the hospital, bring the stretcher, then they're going to alert the receiving facility while still on scene. We used to use radios more often, now we have an app, which gives them real-time ETAs, so they can start spinning up all their internal processes. And then we took a look at this. This is basically a month snapshot before and after we sort of implemented this, and we reduced our scene time by about 4 minutes, which would, as you can imagine, affected the dispatch to backdoor of the hospital. We can only drive so fast in the city and stuff, so that we gained the time where we think we could, and we still do that today. So just give a little perspective of what this is. So the county, and on your right, those are the 22 counties of our region. That's the same size as Connecticut, Massachusetts, Delaware, and Rhode Island combined. And as you can imagine, all the stroke centers, of course, are in the urban area. And then if you zoom in on Bexar County, which is San Antonio, our comprehensive stroke centers, since we're Military USA, like to say are within a small military ordnance range of each other. They're all in the one little spot. We do this area, the asterisk, the red spot, is a new thrombectomy capable that's coming online as we speak, so that's helped a little bit. But it gave us a couple options. Number one, and we'll see on the next slide about door in, door out, but also it gave us a little bit of a natural experiment, because if you zoom in on the city, that outer green is about a 45-minute drive time to the med center where the comprehensives are, and then of course surrounding there are a bunch of other suburban areas that are going to be coming in. When we talk about the really rural agencies, they're going to obviously go to their local facility and either fly in or be driven in. But in the city and the surrounding area, the surrounding counties, we're going to bypass, but we need to bypass with the right patients. And so there was a natural experiment that basically all the units in this part of town were going to go to the comprehensive regardless. So we were able to kind of trial what we ended up doing and saying, well, yep, and looking back at the results. So what we did is, of course, it starts with the FAST. And we use the BFAST model in our system for that initial stroke screening. And I'm going to go through these next slides really quickly, but we had to have that next level of how do we figure out if it's an LVO or not. And so we took a look at the different things out there. Just the Los Angeles scale really didn't get beyond the motor for us. When we went to the Cincinnati Prehospital stroke scale, it certainly helped some, but it kind of didn't talk about vision defects, didn't talk about neglect. And now we're starting to get scales that need math. And you think, well, it's not that hard. In your head real quick, what's the GCS of somebody who's got withdrawal to pain, opens their eyes spontaneously and moans, right? These math things are hard to do in real time and get validity. The legs, also known as the Texas Stroke Intervention Scale, which I put in quotes because it's really the North Texas DFW think they run the state scale. The rest of the state doesn't do that. It's also got a lot of math involved. And then finally, this one, I didn't really know anything about this one until I sort of was putting this together. This one's interesting that it changes based on which side the weakness is on. So that's just going to mess with validity when you're talking about, we have over 1,500 paramedics in our system alone, plus the entire region. So what we ultimately ended up with was the van. And that's what we use to this day. And essentially, you don't get in the scale unless you've got obvious motor weakness. And then going from there, you're going to get all these other areas hit to hopefully be pointing to a large vessel that's going to help that sensitivity, specificity. There's a study or two out there that says it can be 100% sensitive in the ED. In the real world for us, when we ran this, it basically was 81%. And just for clarification, that also is going to include our ICH, internal bleeds. But honestly, that's what the places we were taking them is kind of where those needed to go anyway, so we were fine with that. And then, as I mentioned about some of the reasons why we ultimately went with this was we're not having to do math. Kind of a side effect that was actually kind of nice. It made us kind of in the training get the crews to understand the concepts of aphasia versus dysarthria as well as some of the neglect. So in other cases, they may be picking up subtle findings that aren't going to be an LVO, but might be overlooked as not really a stroke without that extra training. And then the reproducibility of not only our system, but the remaining areas. And so kind of, it checked all our boxes that we needed, and that's, at least at the time, this is what it looked like. Maybe there's some other things now for the other ones, but that's what we chose. And so ultimately, in EMS, we got to have fun acronyms and stuff. So VAN plus FAST became a FAST VAN. And essentially, if you've got motor weakness, you're going to do check visual disturbance, check aphasia, check neglect. And if any of those are positive, that's a positive findings, and you're going to the LVO center. And this is our regional criteria. So in the great state of Texas, we have delegated practice, which means there are no state protocols, there are no regional protocols. It's agency by agency. So we do have, some people use the Cincinnati scale, some people use the BFAST. But ultimately, you're either going to go to a stroke center, or you're going to realize you've got an LVO and you're going to go to one of the big centers. And just really quickly to wrap up, this takes a lot of collaboration. We like to refer to it as co-opetition in town. We have hyper-competitive hospitals, but we do really come together because there's no state rules or mandates that make us do any of this. We do a lot of consensus. We never ever vote, which means it can take a long time to get anything done, but our region actually does a lot of good work on a lot of different service lines. I work at one of the LVO centers, and when they come in as a VAN positive stroke, they're sick. It may not be an LVO, but something bad's going on. So they probably they probably got where they needed to go. And then finally, and this may be a little different from other areas, we have 2 EMS fellowships and a pretty large office of the medical director. So there's up to 15 of us in the cadre, always on call. And so we can do a lot of nuanced radio calls and say, well, they don't seem to be VAN positive, but I'm worried, should I go ahead and bypass a couple places or not? We can make those decisions. Obviously, not everywhere can do that. So that's my part. It should be down here. Let me just X mine. Where are they? Oh, there they are. I think they're in there. Should be your name.
Yeah, perfect. Good afternoon. My name is Lauren Mamer. I'm an assistant professor in emergency medicine at University of Michigan. I am going to spend the next few minutes talking to you about why severe stroke screening is really the best thing for patients. My disclosures, I have grant support from the Center for Advancing Translational Sciences, and then obviously we talk about thrombolysis as a general concept, so there's the usual TPA point. So it's really simple, the case for why we should be screening these patients. 1, time is brain. 2, the tools that we have work. And 3, we know that transferring patients makes their care worse. This isn't really surprising for anyone who's worked in an emergency department. This wouldn't be a stroke talk if we didn't say that time is brain. So I'm gonna say it, time is brain, which is why we spend so much time talking about the minutes that we can shave off of each of the times that matter. Door to CT, door to thrombolysis, symptom onset, like even 4 to 5 minutes, we get excited about improving those times. We know that the things that emergency medical services do help those times. We know that when EMS can do something as simple as give the hospital a heads up that a stroke is coming, more patients get their imaging within 25 minutes of arrival. More patients get their thrombolysis within 3 hours of symptom onset. And we know that those things are good for patients. So why would you take strokes that we know are more severe, that we know need more complex care, and not do the same thing to the best of your ability? We have the tools to do that. We just saw a really great detailed overview of all of the different stroke scales. We know that all of these tools aren't perfect, sure, but they work pretty well. This is a paper that looked at a specific issue that I think comes up a lot with the naysayers, which is like, what if you get it wrong? You've now inserted all these steps, you've inserted all this transport time. There could be a lot of problems with that, and that is absolutely true. What they did was they looked at, okay, like what about the weird strokes, right? This looks great when you have a slam dunk MCA syndrome and like it matches all of the things in any of the scores, fantastic. So it turns out all of the scores do pretty well for the typical ones and not super well for the atypical ones. But what this paper looked at was what happens to these atypical misses. There's basically 2 categories. You had someone who screened positive and went to an LVO center that didn't end up having an LVO. It turns out most of those patients actually had an intracranial hemorrhage and probably needed that hospital anyway, which has been mentioned already. The second component is patients who had this atypical presentation, had an LVO, got transferred to that place where they could take care of it, they missed the hospital They went to the closest hospital because there was an atypical LVO presentation. And so now they're with their LVO at this place that can't take care of that. The problem was a lot of those patients ended up having an LVO that didn't really meet necessarily the intervention guidelines to begin with. So I would argue that some of the misses that we worry a lot about are probably not as concerning as they sound. These authors then went on to incorporate what is essentially the VAN into an algorithm where you do this sequentially, so you don't have to do a lot of math, you don't have to do a lot of like adding and switch which side is left and right, and then you incorporate some eligibility, and they applied that to their system. And what they saw, and I think the most important number on this slide, is that the specificity for this for needing a comprehensive stroke center, which I think is probably the more important outcome, was 89.5%, which is pretty solid when you think about something you're going to implement in the real world in the back of an ambulance in somebody's living room. The final point I want to make, in addition to time is brain and we have the tools, is that we know that transfers are bad, right? Handing off care within your own department to your colleague makes care worse. It's the most dangerous thing that we do. We have all taken care of someone we've either received or sent who has to now go from your emergency department to an ambulance to another emergency department to get time-sensitive care. This is suboptimal. This study looked at 1,000 patients who got mechanical thrombectomy, and unsurprisingly, we are not talking about things like single digits of time. We're talking about like 40 minutes of time for the patients who had to get transferred to get their thrombectomy versus the patients that could get it in-house. That actually, for me, is pretty impressive. They did a pretty solid job. But more important than so it makes times worse is it also makes outcomes worse. So the patients who were transferred and had this extra 40 minutes, they are less likely to be disability-free at 90 days. And that's the thing that patients care about. And so I want to leave you very specifically with the following 3 conclusions. Time-saving steps are still critical in large vessel occlusion, even though we have 24 hours. The last of the 24 hours is not as good as the first of the 24 hours, and we should do everything we can to make that faster. Pre-hospital providers are able to do some really amazing things when you get it to a number of manageable steps they can juggle with all of their competing needs. We have tools that they can and should use. And I think we can all agree that if you have something time-sensitive, anticipating or preventing a transfer in the middle of time-sensitive care is better for the patient and it's better for their outcomes. And these are my references, and I will hand this off to my counterpoints.
Oh, great. Well, thank you, Dr. DeMamar. Tough act to follow. And thank you, Dr. Rich, for assigning me the con, despite several publications I have for the pro. So I will try to convince you, or at least make you think that there's another way of looking at this. So we'll talk about a severe stroke screening. I've already heard a very kind of convincing argument on how a system approach to severe stroke screening in one area and part of the country can actually lead to tremendous changes and improvement in patient outcomes. So this is me. I am an emergency physician. I work at Washington University in St. Louis, where I do some stroke work. I've been there for a few years. These are my disclosures. Nothing kind of out of the ordinary. And talk a little bit about understanding about stroke care. And stroke care is really complex care. And I think early care is better care. I'm going to talk a little bit about the screening tools, which we've heard a little bit about today, about severity, and they're going to understand that they're still imprecise despite what we've heard, and realize that regionalized care and organized care is best care. And I think I'm going to hopefully convince you, and we're all going to be convinced of that by the time we leave. We do know a lot of things already. We do know organized care is good care. All hospitals out there, as you know, are not the same. Every stroke center is not the same. Every comprehensive stroke center is not the same, and that makes a difference for patient outcomes. We know since 2015, with the publication of 15 very important trials for mechanical thrombectomy, that identifying large vessel occlusion has tremendous impact for the severest stroke. But that only is 10 to 20% of the stroke, of ischemic strokes that we see. So 80% of ischemic strokes are not large vessel occlusion. So therefore, we have to create a system that takes them into consideration also. We know that thrombectomy works, and that time is brain. So I'm going to say that. What we don't know is how do we regionalize this? Every system is not the same. Every region is not the same. There are a lot of differences. And what are the roles of comprehensive and primary stroke centers? How do they work together? How do they work opposed? And how do we coordinate them? And what are the implications for pre-hospital care and flow? Because it takes time, training, and effort. And which severity tool is the best? And I think that is the big question, because it must be one that's best, right? Otherwise, I wouldn't be up here. So current evidence, I think, I'm going to trick some of you, if you're residents out here, into learning a little bit about stroke today. We do know that in a pre-hospital setting, leave glucose alone. Let's say you hypoglycemic, treat that, because that can be a stroke mimic. Measure blood pressure, don't treat. For a spoiler alert, there was an article just published today, New England Journal, Interact 4 out of a Chinese population that showed that pre-hospital blood pressure management did not really impact outcomes. But read the study. It's actually fairly well done and really impressive that they're able to pull that off. Oxygenation only if hypoxic. Identify stroke. I think that's really important. I'll agree to that. We need to know, are they having a stroke? That's a big thing. And fast, as we've heard and seen several times, makes a big difference. And if positive, is there a severity screen out there that works? Maybe. And then a couple other things. I think the most important, call ahead. As you know, and if you have a couple minutes of warning or preparation, you really kind of make a big difference in how you approach. Stroke team can be at the bedside, can meet them at the CT scan. You can kind of assign roles, and that's really important. And then head positioning, some very convincing data out there with the Zodiac trial in hospital about head up, head down in large vessel occlusion patients, but nothing in the pre-hospital setting, though we all have suspicions, but more data on that. So triage, that's what we're talking about. Getting the right patient to the right hospital to get the right therapy. And that's what we do, and we do that really well as emergency physicians. But it's often inaccurate. We can't predict what type of stroke they have as much as we think we can. What type, what size, what severity. We can't predict maybe Dr. Cooley can, I don't know, but which patient is going to deteriorate en route and which one is going to have complications, I don't know, and we can't predict that. And in patient preference, I want to go to hospital A because that's where my doctor goes. We've always heard that. And there's lots of politics and policy out there that really direct and really kind of mandate where we bring patients, because if they go by a hospital that is certified for a certain disease, maybe EMS is not reimbursed for that prolonged transport time. So that may actually determine issues. And messaging. You have billboards all over interstates saying that please bring patients to my hospital, we give amazing care. So there's marketing and quality out there competing against each other. So we all saw this, the Cincinnati pre-hospital stroke tool, probably the most common pre-hospital screening tool just for stroke. Though there's a lot of them out there. In a Cochrane review in 2019, they looked at 16 EM-based validation studies of 8 scales, and they showed the positive predictive value anywhere from 34 to 58% with a sensitivity of 64%. So they're not great. They miss a lot of stroke. They miss posterior circulation stroke, which is 20% of the stroke we see of the ischemic stroke patient population. So I mentioned in 2015, kind of an arms race in mechanical thrombectomy came, and it really kind of changed how we identified patients in the pre-hospital setting. I do a lot of volunteer work for the Heart Association. They reached out to me and a couple of other colleagues and said, can you put this EMS service routing algorithm together? We don't really have any data to support it, but how can we say if a patient's having a stroke, how do we get them to a thrombectomy center? So we said, let's just do some validated screening tool to see if they have an LVO. I don't know which one works, don't know. I don't know if I can convince you we know that. And then once we do that, if it's suspected, can we transport them to a thrombectomy center preferentially? And how long is too long? How long is kind of a bypass? We don't know, and we can see over time we kind of try to pare that down a little, that we saw from whether you're urban, suburban, or rural, what would be too long, what would actually cause harm. So we came up with that, and we really based it upon conjecture, expert, we sat around, had some coffee and said, this is what we think is best practice. And we said, if we at least put it out there, maybe the evidence will come. And then it started to come. We started to say which tool was best. We had the Presto study that looked at 8 severity scales and came up with the kind of comparing to the NIH stroke scale, which is really the gold standard. It takes anywhere from 5 to 7 minutes to do. It takes training. For those of you who have not trained in it, once you get trained, you realize you were doing it wrong every time you did it previously. So you have to train to do it. Not practical in the pre-hospital setting, just because it involves a lot of training, and you have to use it frequently to be good. And we looked at all of these, and what we found that for anterior LVOs, it was acceptable to good. I don't know, that's not really convincing to me. Acceptable to good, and performing pre-hospital stroke scales, to identified LVOs, and further studies are needed. So further studies came, and we had this study that didn't look at LVO screening tools specifically, but it's based out of Catalonia, Spain, called the RACECAT. And they actually did a randomized trial of bringing stroke patients to either primary stroke centers or thrombectomy-capable centers in a kind of rural suburban area in Spain. And what they found is, and it's amazing that they pulled this off, that of 482 that went to thrombectomy and 467 that went to a local stroke center, and 75% of the patients who ended up at either of those destinations had LVOs, there was no difference in outcome. So it kind of makes you pause, despite what we've just heard, that larger hospitals give better care. So as a result, I agree, stroke is time critical, pre-hospital identification is important, and some patients require advanced stroke care. How do we predict which one? We don't know. There's current stroke screening and severity tools are imprecise. There's not a best one out there. Data on preferred hospital triage is conflicting. Transporting every patient in your region to your emergency department during your shift, not practical and not recommended. We can be overwhelmed as a comprehensive stroke center. And most patients can be treated locally, effectively, and well. And if they need advanced care with our well-integrated inter-hospital times that are not very long at all, right? What does it take, 30 minutes to get a patient between two hospitals? More like 2 hours, but we can do that. And then if they need to be transferred, we can do that. And what we really know is more research is needed to actually make definitive statements. Those are my resources. Thanks.
All right, so initially I was convinced that we should 100% do this. Now I really don't want to do this, at least in my EMS system. Dr. Netwich is going to tell us why these are really good things for our EDs that we work in as well.
Great. So hi, I'm Lauren Nentwick. I am not a stroke person. I actually am vice chair for clinical affairs for the Department of Emergency Medicine at Massachusetts General Hospital in Boston. So I actually wanted to be a stroke doctor like Dr. Panagos way back when. And so when I started my career, I spent a lot of time thinking about stroke. And then I realized how messed up the operations were throughout the entire ED and got pulled into that. But I still really, when I think about operations and I think about how operations should work, I think about all that's been done in EMS, all that's been done in stroke, and how well it's done. And sort of that's how the streamlined effect and how we want our EDs to run. So I have no disclosures, and I feel like as an operations person, I got the easiest pro to defend ever. Like, basically, of course I want to know when EMS is coming. Of course I need as much time as possible to get ready for the strokes. We do a lot of amazing things. If I know a stroke is coming, I can be even more amazing. So, talking through this. So I think about stroke pre-notification in any one of its forms. So EMS triage letting us know who's there, air medical transport bringing them in, and then even really the inter-facility transport. So another one of my roles is I'm a capacity MD for Massachusetts General Hospital, which means I literally spend most of my days thinking about, can we take this patient or will it just cause us to go over the tipping point? Could this patient go to a different hospital in the New England area in the MGB system? So a lot of this is weighted as we think about what we're doing, and the more time we have to think about it, the better care we can provide the patient. So looking through this sort of, when I think about how I started doing stroke, it was kind of like this. EMS would bring us patients, we'd get them to a room at some point once they finally got through triage, and then we do 1,000 things here, and it took us forever to get anywhere. Now we have pre-notification, and with the pre-notification, it gives us a time. We know the patient's coming, and we know what they need, and so we can call the people to be there. We can get the room open. We can get the CT scanner open. We are ready to go. We are going to provide much better care for this patient. And then C, that's where you bring the stroke room to the patient. We don't have that in Boston. Our transport times are ridiculously short, so nobody wants to fund a EMS truck like that. So, hospital crowding. So I was woken up at 4 a.m. this morning by my pager telling me there were 85 boarding patients in an ED with 77 beds. I know you all experienced the same thing. Everybody's ED looks like this. We all have experienced increased boarding, increased crowding. We've got no room to put our acute patients. It wasn't like and it just keeps going up and up and up. We need time to get ready for these patients. We need time to get ready for our sickest patients. We do it for our STEMIs. We do it for our STEMIs. We do it for our traumas. We need time to get ready for our strokes, especially our strokes with large vessel occlusions. So we need time to assemble our team. We need our stroke team, our ED team. We need our nurses there. Places that don't have a neurology primary, I'm very privileged that I have sort of anything I could want that could come down at any second, but places that don't have their neurology team on site needs to be able to get their teleneurologist ready to go, ready to see the patient, and then really interventional needs to know that the patient is here. They need to start to get ready. They need to think about the cath lab. I mean, we activate ECMO from the scene, so EMS calls in and tells us they have an ECMO patient. We activate the ECMO team. EMS calls and says they have a STEMI patient. We activate the entire cath lab. It's no difference with stroke. It's, in my opinion, it's the way we have to go and way we have to think with time as brain. We need time to prepare, depending on where you go to, whether it's the age-old debate of whether you go and you do your quick assessment in a room or whether you go straight to the CT. But I don't know how many people's ambulance bays has just one patient in it at any time. Like, literally, our ambulance bay is all the way back, right? And what I need is, I need to know the sickest patients coming through, and I need to wave them through. And without pre-notification, without knowing what the scores is, I can't prioritize my patients. And then, obviously, target stroke, we all know is sort of, target stroke, we all know that it had the 12, pre-notification was #1 for the 12 best guidelines that came out way back in phase 1. The times just keep getting shorter and shorter for IV therapy, and then endovascular therapy, door-to-device time of less than 90 minutes for direct-to-door, and door-to-device time for less than 60 minutes for transfer patients. I don't know about your places, but it takes us a while to get that cath lab open that's running with all the other things and get that patient up there. So really, it's kind of a no-brainer to me, and sort of, I know, I couldn't find any of the, I defer to my stroke colleagues, I couldn't find any of the endovascular literature on whether or not pre-notifications increases endovascular, but we all know that it does for TPA, and so it just makes sense to me that for thrombolysis it does, and just time is brain, and time is preparation. And then, like I said, my other job is working as a capacity MD, and so thinking about where do patients go in our hospital, and if we have notification, we can get patients to the right place. The other day, we had a dissection come to our ED from an outside hospital transfer, and no one knew it was coming. And you can imagine the tamponade and the bad outcomes that ensued. It was bad. So again, a no-brainer. If you know that a patient is coming, you can prepare for them. You can give them the best care. We do magic every day. We just need to know as early as possible what we need to do. With that, I'll pass it off to the cons.
All right, I'm back with you. I want to keep doing the Cincinnati. I'm sure that's the way to go. I'm sure I can't be convinced otherwise now at this point. All right.
Awesome, thanks. Dr. Nutwick, thank you very much. I feel bad, I have to be your con, but I was told by Chris I have to be the con, so blame him, not me.
I'm a bad guy.
That's right. I'm Jamal Sosner. I'm one of the faculty in emergency medicine as well as on the stroke program for the University of Michigan. Great to have you here. You all make decisions, and I'm very impressed you guys chose us instead of an early happy hour, so thank you for being here. But let's see what we can do to make things muddier for you. I have no pertinent, obvious disclosures to give you. Let me see if the sucker works. Awesome. I do want to say, I'm going to try to boil this down into everything that you need to know about stroke systems of care you learned in kindergarten, if you'll believe that or not. But at least we can kind of talk about the Goldilocks theories here. We're going to use some very similar, I think, data, but I think we're going to look at it slightly different. So I'm sure you guys practice in the same place I do, which is just kind of ridiculous, right? We have patients that are, coming out of every single corner. We're putting them into closets. We're putting them into hallways. We're creating signs that are not permanent to say that, this patient is in room 25, whatever the case may be. No, I didn't want to use one of ours as well, yeah. Our shop is much worse than this. But so anyway, the last thing I want is yet another patient. And certainly I don't want the patients that don't need to be at my facility to come into my facility. And much of the, many of the comprehensive stroke programs out there are academic shops that are just kind of bursting at the seams like this. If you look at the data, again, I think we use similar data here, but for about 10 years, we were seeing that ED boarding was staying fairly static, but somewhere around 21, post-COVID, when length of stay in the hospital started to rise, we started noticing substantial increases in ED boarding time, which is just killing our operations. In addition, when you start looking at the data for left without being seen, which is the graph on the right, that was out of JAMA a year back, that shows that, again, we were fairly static. Then again, we're starting to kind of have a significant rise, which is telling us we're just not able to care for all the patients that are coming to our hospital. So it's going to be important that we're kind of selecting patients that need to be at our facilities. When you combine that with my colleague from EMS had already mentioned some of this, but the challenges that EMS faces, this is a busy slide, but I'll kind of draw your attention. This was last year. This was an EMS report that came out of a consulting company that did a lot of national data gathering from survey work. But they noticed across the country that there was about a 52% increase in systems that said they weren't able to kind of provide ambulances to non-emergent traffic. Which non-emergent, you can say, okay, what's the big deal there? But when you start looking at emergent traffic, it was a 47% increase in systems that were not able to provide timely care, and they were seeing their transit times getting to those facilities or to those home addresses increase. Combine that with the workforce problems. 48% of those that were surveyed during this survey last year that were in EMS said that they will be looking for new jobs or looking for early retirement because they felt that working in EMS was not a sustainable path. So that is truly an emergency. And then that graph to the right is essentially showing all the EMS systems that were surveyed that said within the past 3 years they've had substantial challenges in terms of staffing all of their ambulances. The vast majority said yes, they do. So again, I'm kind of trying to paint a picture that you all know very well that we're in a very, very bad situation. Back to Goldilocks. So the porridge is too hot, over triage. Do we want to bring all those patients into the comprehensive stroke programs? And again, I'm conflicted as well. There are some pros and cons that I agree with. Again, here I'm in the con. I'm going to tell you that if we direct all patients to a higher level of care, or if we deploy some of the large vessel screening scales that we have, but have a low specificity on those scales, we're going to push all those patients into a comprehensive center or into a thrombectomy capable center. What's that going to do? That's going to increase the burden to that facility. Remember, you have a lot of stroke mimics, a lot of stroke patients even that come to that center that don't need to be there, that can be very well cared for in smaller centers and kept there as well. There are opportunity costs, right? So you're going to pull these patients into your resus bay or into your acute care setting. You're not going to be able to take the next patient out of the waiting room. It's got very real world problems that we're introducing to the patients that don't come in with stroke symptoms. And then a delay in therapy. Obviously, if these patients are driving further distances to get to definitive therapy, which may be thrombolytics for them, you're delaying that thrombolytic administration, assuming that a closer hospital could have done a good job or an efficient job at giving the thrombolytics. So looking at what happens when we decrease the number of patients flowing to the acute stroke-ready hospitals, the primary stroke centers, one, the delay in therapy that I just talked about, but also we have to realize that we're decreasing their ability to improve or the proficiency that they have to treat patients. The fewer patients they treat, the less likely they're going to be able to improve their systems to treat the next patient faster or more efficiently. You're going to remove that patient from their community and their family, their support system, so that's got real-world consequences as well. We're not very good at sending patients back after they have gotten the therapy that they need in the larger centers back to the hospital that their family is closest to, so unfortunately you've got a lot of families that are traveling back and forth. What does it do to our EMS system? It increases burden on them as well. Of course, as you can imagine, we're asking our colleagues in the back of a rig to make big decisions in terms of pulling their ambulance out of their community into a different community, transporting that patient with very, very little data in the back of the rig, and that's not very fair to our EMS colleagues. And of course, we're compromising the community, right? So you pull an ambulance out of circulation, you've got fewer ambulances to respond to other critical situations. What happens when our porridge is too cold? So under triage, so this is transporting patients to the closest thrombolytic capable center, or putting in screens that are so specific that you're going to unfortunately just take the very, very kind of top, the cream of the crop that's going to need to go to a thrombectomy capable center. Well, this is going to obviously delay thrombectomy times. When we start looking at national door-in, door-out times, there's a beautiful article that was written and published last year in JAMA, and the two primary authors are actually right back there in the room, did a great study, and they looked at over 100,000 patients that were in the Get With the Guidelines database for stroke, and they looked to see what the door-in, door-out times were, and they found for all strokes, it was 174 minutes, I think it was better for patients that needed thrombectomy, but yet, we're above our goal of 120 minutes, which was set years ago by, the Joint Joint Commission, as well as a collaborative kind of study. But we want to get those patients in and out within 120 minutes. We're still missing that goal dramatically in most centers. So you're unfortunately introducing a significant amount of delay for patients that need thrombectomy. Systems are inefficient, and then obviously TPA and LVO. We all know that thrombolytics, while they're good for smaller clots, less good for big clots. TNK has improved that a little bit, but it's still kind of problematic. So again, impact on sending more patients to the closest center that's able to deliver thrombolytics. You're assuming the system is efficient. You don't know if those hospitals are providing that thrombolytic fast or not. You're making that assumption. Availability of specialized care. My colleagues had already mentioned a lot of these hospitals may not have neurologists or even telestroke that's capable or available to them. So you might be putting patients into a situation where they don't actually have the best resources available. And then the transfer reluctance. There are plenty of hospitals, we've dealt with them in our system as well, that say for business reasons, we will not transfer a patient out unless they have a proven LVO that needs to go to a thrombectomy center. And that typically is going to require their radiologist to read the studies. We've had centers in the past that have taken up to an hour to read those studies. So again, you're introducing significant delay that leads to substantially worse patient care. EMS, you're calling for a second ambulance, pulling another one out of circulation. That's obviously horrible and compromises the community as well. And then is the ambulance appropriately resourced? Some of these patients that get thrombolytic agents, they have to take a MICU rig or something, which is even in hotter supply, or in fewer number of supply in the community. So the porridge is just right. So what do we do? Chris is going to tell us the answer to this in a second, which is going to be fantastic because I can't wait. But we have to also understand that there are some issues that we need to tackle as we're developing these stroke systems of care, right? There are extrinsic and intrinsic factors. Intrinsic is going to be, those that we can't control, those that paramedics can't control, the patients, the number of collaterals they have, their biologic makeup, whether or not thrombolytics may work on them. We can't figure that out in the back of a rig, but some things that we can figure out are extrinsic factors, and these are hospital level data, and knowing the data for the hospitals around our community for the paramedics to be able to kind of pick and choose which patients should potentially go based on the outcomes and the data from those hospitals. But let me stop there because that's very simplistic compared to Chris, who will give us the answer. Thank you.
Or just keep muddying the water, as is the case. All right. Well, so the last part of the slides part of this is to talk about, yes, how can we increase that just right pot of porridge that we're looking at? And really a lot of this kind of focuses on what are some of the innovations that are happening in this space to optimize our ability to identify these patients in the pre-hospital setting. Coming back to the intro slides and the stroke chain of survival, how can we optimize this whole system? How can we strengthen this entire chain? Well, first off, we want people who are having strokes to access the EMS system, to access the hospital so we can get them treated. The AHA, this is actually a fairly new development. Could have happened a while ago, but it's great that they're happening now, which is actually doing a structured research into Spanish language, basically fast translation, and what is the best way to identify stroke for non-English speakers. Ahora has been studied, Rapido is what the AHA is going to be going with after a period of study. And then there are online resources for people to go and learn about strokes. This actually, if you go to the AHA website, it's kind of a fun game you can play with this brain-looking guy. You can actually go and give yourself a facial droop, which is kind of cool. But what's also really cool is that now with AI, our own phones can pick up when we're having a stroke, right? And so if I have my iPhone and they're telling me, hey, you have a facial droop, go get that checked out, hopefully that's going to increase that layperson recognition. I think a lot about kind of the interaction at the level of dispatch. It's a very complicated, if you've never sat in a 911 dispatch center, please do. It is a real tough job to identify that a stroke is happening. And in fact, the call takers rely a lot on what the person on the other end of the phone is telling them. We did this in Chicago where basically if the caller uses the word stroke, those call takers are much more likely to actually dispatch out an ambulance for suspected stroke rather than something more nonspecific like a sick person. And in fact, the next step here is, again, AI to augment the call taker's recognition of stroke by listening to some of those things that are in the background that the call taker may not necessarily pick up on. Lastly, with our EMS practitioners on scene and optimizing that right care, right time, right place, which is we've talked a lot about screening with these different scales and recognizing that none of them are perfect. Is there actually a way to move from screening to diagnosis? Because if we have actually an on-scene diagnosis, then we can really optimize the right care at the right time in the right place for these patients. And so lots of things are currently in the works. Things that use EEGs and microwaves and accelerometers, looking for differences in blood flow to one side of the brain or the other and differentiating between ICH and large vessel occlusion. Those things are on, essentially the application is some sort of helmet that goes on the patient or a visor or something like that. But at this current state, and a lot of work is being done, these still are, maybe on par with some of the LVO screens, maybe a touch better, but still there are still screening and test characteristic challenges even with those helmet-based things. So is there another way that we can move from screening to diagnosis? Well, one example is the mobile stroke unit, and they're great if you have them, if you have an institution, but basically mobile stroke units are an ALS ambulance with a CAT scan, with either an in-person, but usually a teleneurologist or telestroke specialist, and the ability to treat stroke. So if I'm thinking about a way to diagnose and deliver the right care, if I have in my current state of affairs a CSTAT, a Cincinnati Stroke Severity Score that's really high, and I know something bad is going on, well, if I compare that to this picture right there at the patient's curbside, I can start giving blood pressure management, reverse the anticoagulation that the patient may be on, and know that they need to go to a comprehensive stroke center for sure. That's a lot different than looking at a CSTAT-4 patient with a non-contrast CT like this, or maybe even a CT angiography like this with a big large vessel occlusion in that left MCA, where I can start giving thrombolytic of choice and then know that I'm pretty good at bringing them to a CSC or a TSC, which gives me some more options from the ED capacity perspective. So ultimately, there's a lot of things going on to strengthen that stroke chain of survival to help us increase that big pot of just right porridge, and we look forward to that. Right now, we're kind of in our current state of affairs, and with that, I will open it up to questions from the group. Otherwise, you get to endorse some of my own questions. All right, thanks everyone. All right, so any questions from the group or even for the panelists to each other?
So we do not have as I said, Boston transport times are very short. We do not have a mobile stroke unit. I worry a little bit, sort of like an ALS call to a stroke, that you start messing around on scene and you just prolong your scene time when you really just need to get them to an ED. And so I'm just curious, like when you've used your mobile stroke, like how long is your scene time for those patients?
So mobile stroke units will necessarily increase scene time. Our on-scene times are about 35 minutes or so, give or take. And at least initially, our partner, our EMS agency, we cover 25 suburbs around Cincinnati. And they were kind of hesitant about that. But the way that I like to frame it is essentially it is bringing the acute stroke-ready hospital to the patient's curbside. So everything that can be done essentially in that first half hour of the stroke patient's care is now happening at the curbside. We're talking to patients and we're cutting out that necessary transport time to shave off 30, 45, maybe even more minutes. And then I know that they're going to be brought to a center that is matched in terms of capability.
So I think they still have it active. Houston has one of these. We were asked to have one of these. Much like the labs in the field, we politely said, hell no. And the debate becomes an interesting debate because you're right. I think in some settings and in some services it may make sense, but you do have to stop. How much does your stroke unit run?
Startup is at least $1 million.
Right, and you're paying the neurologist, and I'm sure there's a lot of continuing cost in that. What can you do with public education for that earlier detection? What are the things you can do? And it depends, again, if it's if it's equitable across the entire system, that's kind of a different debate. If it's, well, we only like, I know when Houston started theirs, and I don't want to speak for them anymore, but there was a very narrow little area near the med center where it was, which was not necessarily equitable at all for the population. So these are kind of the questions you have to have. And from an EMS system, I would much rather spend that money on a lot of the things we've spent it on than a stroke unit. So it may be the future, and as cost comes down, and I know they've even got stroke helicopters out there now with CTs, but it's something that has to be very careful because much like the proponents are very pro, but there's a lot of factors to that.
So you brought up an excellent point earlier when we talked about when you were looking at the literature search on why we don't have some really good door-to-device time research out there versus IV for pre-hospital notification. And I think if you think about it, it makes a lot of sense. We have these stroke teams that are ED-based that get a pre-hospital call that comes to the ED and the team is activated and they go right to see the patient. For our thrombectomy cases, unless your thrombectomy team, neurologist, neurosurgeon, or radiologist is on part of the stroke pager as part of the pre-hospital activation, they don't know until you invite them to the party. So that means you see the patient, evaluate them, weigh them, do an NIH stroke scale, get labs, get an IV, get an ultrasound, a guided IV. Once you fail to get that attempt, get a CT, get a CTA, LVO, then you call them. You don't get a lot of time benefit from that. If they wanted to be part of the noise and get every pre-hospital activation call saying possible stroke, then potentially that'd make a difference. Our door-to-needle times, or door-to-device times for transfer hospitals, where I'm taking telestroke call, I'm looking at the image at the outside hospital, I'm saying LVO, I'm talking to my interventionist on the phone saying, I'm transferring this patient, their ETA is probably gonna be 90 minutes. And then when they hit the door, the team is already activated and they have really short door-to-device times versus seeing patients that we can't get under 90 minutes if we try, unless it's perfect, like noon, not noon because everyone's eating, 10:30, they're between cases and somehow the bed is available. So I think there's opportunities there. STEMI obviously did that many years ago where we have pre-hospital activation for possible ST elevation. But that's a biomarker that we don't really have for stroke unless we have a stroke mobile.
Will Moyer, University of Michigan. Disclosures, I get money to do telestroke from the university when I take call. I think though that this might be, I think there may be a technological solution that we already have. I think to me as a telestroke doctor, they're like, this person's arm's weak. I'm like, dear God, why did you call me, right? Do a CTA, and I think that there's been a little controversy in terms of doing CTP up front, but CT, CTA, CTP, they hit the door, you get that within 10, 15 minutes. You have a regional system where you can see it all. It doesn't even matter if the radiologist is like, I'm going to read it in an hour. It's like, okay, then we're not going to pay you because you suck. But AI is going to read it in 5 seconds, and you're done. You know exactly what the patient has. You push thrombolytics, you get them going. If you had administrative superpowers, you could be like, please ambulance, wait for 15 minutes while I get, go get yourself a cup of coffee while I get the CTA and get this person TNK, and then they buzz back off, right? In terms of the stuff that we have in the world right this second, we have CT scanners, we have Rapid AI or Viz AI, I'm not beholden to either. We could just more standardize across all of these regional areas, just get it, you have more diagnostic certainty with the CTP, so then you don't have to be like, do you really talk like that? When you're trying to figure out this person has aphasia or delirium, or they're just, from a different, they're from Texas or something. Sorry, that was super mean. Although I've been to San Antonio a few times, I didn't know how to say the name of the county, so that makes me super lame too, in that sort of reverse way. But yeah, no, I've been thinking it's Bexar County for 20 years. Anyway. So I guess, what do you think? Can we just change does that moot this question, right? Just get some place that has a CT, CTA, CTP. It's going to outperform everybody anyway. Get them to the thing that performs the best as quick as possible.
I agree with that.
Really quickly, I didn't touch on this. I mentioned our dispatch system does some pretty cool stuff we've got a system in place now, and again, this kind of alludes to the technologies in place to figure this out, where they can pull up they can basically hijack the phone of the caller and get the video, and not only they can physically see them and see what's happening. You can see the facial drip, you can see the stroke findings, but it also can detect pulse rate and respiratory rate pretty accurately, and blood pressure is working on. And that's we actually use that system for more low acuity calls, to be honest, that they don't even get an ambulance sent. But we've seen that on high acuity calls. We see it with CPR. We see it with those kind of things. So that, again, that's where if you can really see from the dispatch standpoint while the units are on the way, you can say, yeah, this is clearly a stroke. Now we need to fire up whatever system we want to fire up to send them where we want.
Well, thanks everyone. Our system, we actually have CTPs at basically all the hospitals that we cover, but that's a fortunate thing that we have, and I know that's not universal. I know that our endovascular folks are kind of like, let's maybe save it for cases where we're really on the fence, because we could maybe get some noise in terms of like CTP information as well. But
I don't think it should ever talk them out of using, going after an LVO, but I think the potential value of getting it so early is it just lights it up immediately. Like, you don't have, like, if you're like, oh, is this an M2? Is this not an M2? The CTP just, it improves the diagnostic accuracy and lights things up right away. So I think, who on those endovascular people? Like, just get off from an emergency medicine perspective, it gets the patient the right care faster by having that additional information. And to sort of be like, oh, well, we'll think about it. I want to look through the CTA for 8 minutes and sort of say, oh yeah, get a CTP on this one. Like, no, right? We want to get the right thing going as soon as possible that gets us all the information we need. I think as long as it's not talking us out of doing it in spaces where it's unvalidated, as long as it's only making us do things faster and better, I think it's okay. But I think that's a way to make this all better.
so some like really well temperatured porridge going on over there. I appreciate
You
that.
have to call me less on telestroke, so I can just sleep. Right? I'm like, oh, yeah. I have all the information I need for this thing. And
Love
they
it.
probably stop paying me, like, but that'd be okay too if all the patients got better.
There you go. I think another session's in this room at 5 o'clock. I really appreciate everyone's coming. Thank you so much.